Good evening. Guess what time it is? It's 4 o'clock in the mountains, which means 6 o'clock on the East Coast, 3 o'clock on the West Coast. And there is only one place that you should be right now, and that is Fertility with Fink and Friends. Good evening to everybody. I'm Dr. Randy Fink, live from CNY Fertility in Colorado Springs. I am also the medical director at the Miami Center of Excellence in sunny South Florida. And it is great to see all my friends stepping in. Hello to Haley and Melissa. Baby OB21, I like that. Hi, Leah. Oh, hello to Allie, a special guest here. Looks like our first to join tonight is Cicely Wee. Thank you. On my Instagram over here on the CNY Instagram, I've got Rashmi and what happened there? And Rashmi and Ashley. That's a hard one to say. Dog Mama Cass. Hi to No Jolson, Facing Destiny. Good to see you this fine evening. Jackie Scroggins is here with us, as well as Nina Buena. I like that. Arlene, our first to join on the CNY side here is Brandy Lynn. Thank you for being here over on Facebook. We've got Facebook and YouTube right here in the middle, and LinkedIn as well. That's Melissa is the first to say hello. And it's great to see everybody. I hope your week has been great. We got a little bit of snow here in Colorado over the weekend and a little bit, I think, last night or the night before. Kind of the days start to blend together, but fortunately, nothing terribly significant, nothing to slow down the beautiful progress of folks making their families. How are you doing with your New Year's resolutions? Mine was one of mine was to kind of try to stop. To sort of work on the ever expanding girth of the waistline here. And so far, so good. I would say I can't complain. I can always find something to complain about. So, but cutting down on the snacking a little bit, trying to clean up my act somewhat. And so far doing okay there. Well, let's see what you guys are talking about tonight. Haley is saying, I had my daughter at 29 weeks and 1 day on Christmas Eve. Does IVF affect babies coming early? We still don't know a reason. What sent me into preterm labor? Well, gosh. So at 29 weeks, your baby's probably still in the NICU. Most of the time, 29 weekers do very, very well. They're typically, leave the hospital really completely normal. But there's just a little bit of some stuff about learning how to stay warm and learning how to eat, learning how to maintain blood sugar and things like that. So that's kind of the learning process that they still have to go through, and those are things that would otherwise happen while the baby's on the inside. So I guess you got probably a little bit of an earlier Christmas present than you would have anticipated, Haley. And I know that's all a scary thing, but I feel very confident that at 29 weeks, your baby's going to do very well. We really don't know, what causes preterm labor. It's some people think that it may have to do with a little low-grade infection. It may have to be a low-grade infection that is happening inside the uterine cavity, inside the amniotic sac. Can be, really any number of things. IVF specifically is not known to cause preterm labor, except in the case that IVF is more associated with multiple pregnancies, like twins. So if you have twins, then the risk of preterm labor is dramatically higher. It's very significantly higher. So in that situation, we do expect preterm labor is not uncommon. But with a singleton pregnancy, Haley, that shouldn't have been an issue there. But gosh, how scary! But congratulations in advance of bringing that beautiful baby home, and can't wait to see some pictures. I keep seeing that we're having some connection issues over here a little bit with the CNY. Instagram side. So hopefully that will resolve itself. And thanks for sticking around and being patient. SC Votla says, would I be a good candidate for PRP? I am a 42-year-old woman with endometriosis and diminished ovarian reserve. So, really, the rationale for PRP is due to that ovarian reserve problem. So, and you bring up a great point there, my friend. Thank you for mentioning that, because there's two things I really want to stress here. Really, kind of one thing with two avenues, and that has to do with egg quality and egg quantity. Because when we're doing IVF, what we really want to do is to be able to stimulate the ovaries so that we can have you make as many eggs as we can get, which we then retrieve from the ovaries. The more eggs you have, the more options we'll be able to have. Potentially, the more embryos we're able to make, and the more options that gives you down the road about what we're going to do with those embryos. Um, Egg quantity, how many eggs you have, and how your ovaries are going to respond to the medications we use, is something that's, I would say, is largely out of our control. It's not out of our control because we can use different kinds of medications that may be able to give us, a slightly different type of response to IVF. But you're born with all the eggs that you'll ever have, right? We can't put eggs back in an ovary. We can't make more eggs appear when over time those eggs will diminish, and they will naturally diminish over time. And that is something that we measure with the AMH hormone, the anti-Mullerian hormone. It's a simple blood test. If you saw my Instagram post, actually I put that on CNY as well yesterday, I think. If you don't know your AMH level and you're thinking about wanting to have kids, AMH is probably the single most important test we look at to figure out how well you might do. The AMH is theoretically not associated with telling you how you're going to be able to get pregnant on your own, but it tells us how you're going to respond to medication. And even though it gives us a number, it more qualitatively assesses how many eggs are left in the ovaries. Because once we reach menopause and the ovaries are empty, that AMH level should theoretically be non-detectable. Usually if it says less than 0.03, that's often the lowest threshold that the lab can detect, then that suggests the ovaries are done. That's fully a menopausal level of AMH. So the quality of the eggs is a different story. That means how stable is the DNA? How well put together is the genetic material in the eggs, which of course also does decay over time. Now we can look at a graph, and we can see a fairly steady decline like that, kind of going down this way when we look at AMH levels associated with age, because, well, that's one of the reasons that it gets harder for women of a certain age to start to get pregnant. It's because the AMH, the ovarian reserve, is going down. Again, all the eggs you'll ever have, you're born with. We can't put any more eggs in the ovaries than are there to start with. But what we may be able to fix or at least adjust or do something with is the quality of the eggs in the ovaries. And that quality is referring to the stability of the DNA. So when you have diminished ovarian reserve, and I suspect that at 42, you probably also have, you've got a lower AMH, which is kind of how we define diminished ovarian reserve. There's also an issue with egg quality there. So putting PRP into the ovaries, or platelet-rich plasma, that's the portion of your blood that has your own body's healing factors in it. So we take a tube of your blood and are able to separate out the portion of it that contains your tissue factors, your growth factors, all those things that help us to heal. And we can place that PRP directly into the ovary. That's what's called intra-ovarian PRP. That is particularly useful in folks with egg quality issues, especially associated with diminished ovarian reserve. That's where we most commonly use it. But there are also places where you may have someone who's in their 30s or maybe even in their late 20s who have egg quality issues for one reason or another. And the thinking is that ovarian PRP may be beneficial in that scenario. It's still considered experimental. So what does that mean? Well, we don't know exactly how often you should do it. We don't know what the perfect interval is between PRP and treatment. How long does that PRP last? Those are things that we really, we just don't know. So that's why I say it's experimental, but I've seen very good outcomes with it. And my friend, I do think it's a reasonable option for you. It's something that we offer at our CNY facilities, and something that I encourage people to look into, to consider. Over on the Facebook side, hello. Oh gosh, we've got a bunch of people who joined over here. Paige is the first to ask a question here. Why do some people have egg retrievals scheduled so far in advance? Well, there's only so far in advance that we can schedule an egg retrieval, because the retrieval has to be done really precisely 35 hours after the trigger shot. Most people, for their trigger shot, they're using both Lupron and HCG. Some people will use one versus the other, but we can't schedule that until we know when that trigger is going to take place. How can we know when that trigger is going to take place? Because remember, at the start of your IVF cycle, you are contacting us on cycle day 1, right? So do you know when you're going to ovulate? Do we know when we're stimulating your ovaries how fast they're going to respond, and what, how quickly they're going to grow, and when more than 50% of those follicles are going to be of a mature size? No, we don't know that. So we really can't say. Sometimes you can get an egg retrieval scheduled maybe a week in advance, because we might be able to predict, well, okay, given the way these things are growing, and maybe you're having a difficult time getting the right kind of monitoring done. If you're monitoring remotely, it's hard to find a place, or they're not getting the results back in a timely fashion, or one problem or another. We may be able to kind of predict and say, okay, looks like you're probably going to trigger at this point, 3 or 4 days from now, and that means that 35 hours after that trigger, we're going to do your egg retrieval. So that's really the only scenario I know when people can have those retrievals scheduled in advance. Let's see, pros versus cons for gene carrier testing. The Beacon test is the one that's run by LabCorp. How does that relate to if we are doing PGT testing? And this comes from Melissa, and that's a great question, because they're two completely separate things. So the carrier screen is that we've been able to identify, and I say we, I mean absolutely not me. It has nothing to do with me or CNY for that matter, but those in the science department have been able to identify on the human genome, so on our chromosomes, we've been able to identify the locations of about 500 or so different genetic diseases. Now, most of these diseases are things that even I've never heard of. Most of them are really pretty rare. But some of them are things that you have heard of. They're more common. So, cystic fibrosis or sickle cell disease, certain types of muscular dystrophy, and the list goes on. Some of them you've heard of, but most of them are fairly esoteric things that are rare diseases, fortunately, and many of them are things that are known as inborn errors of metabolism that can cause devastating effects or fatalities in infancy. So they've been able to locate on the chromosome where these things are. So we can do a simple blood test from you to determine whether you are a carrier of any one of those genetic diseases. And if you are a carrier, all that means is, and it's not uncommon because there's 500 of them, so not unusual to find that you do carry something. But if you're a carrier, then we want to test male partner, who may very well be a carrier of something too. But if you both happen to be a carrier of the same thing, it gives you a 1 in 4 chance of having an affected baby. And so the time to find out about that is before you get pregnant, because in our line of work, we can prevent you from having an affected baby. That carrier screen is considered a standard of care. You don't have to do it if you don't want to, but you're taking a risk because these situations are preventable with the type of genetic testing we can ultimately do of the embryo. So that's a standard of care in fertility, but the PGT testing is something completely different. PGTA, or pre-implantation genetic testing for aneuploidy, is how we grow an embryo up to a certain stage known as a blastocyst, and we can take a few cells from the portion of that embryo that's going to become the placenta. Those cells go off to a lab known as Cooper Genomics, and they're able to test the chromosomes of your embryo. Now, most of the folks who do IVF, if you place an embryo back inside and it doesn't stick, the most common reason for that happening is because the embryo itself is just not normal, that there's a chromosomal issue, a genetic issue. Generally, I mean, it can come from the sperm, but we often think of it as being an egg quality issue. It has to do with the DNA within the egg. Potentially, the sperm creates an embryo that's not normal. If you have an abnormal embryo in terms of chromosomes, those embryos typically don't implant. You just never get a positive pregnancy test. Or it can implant and result in either a biochemical pregnancy, and that's really the reason for having a biochemical pregnancy. And a biochemical pregnancy is where your pregnancy test turns positive, the hormone level starts to go up, but then it kind of stops and starts to roll back the other way before you've been able to see anything pretty early on in that pregnancy process, usually within the first week or so after the positive beta. Or it can end in a miscarriage, and most miscarriages happen as a result of chromosomal issues. So if we have a whole big bunch of embryos, let's say that you make 10 embryos. All right. Well, how likely is it that all 10 of your embryos are going to be normal? Odds are pretty against it that every one of your eggs was normal, and that every sperm was normal, and that every embryo was normal. That percentage of how likely the embryos are to be normal is based really on age. So let's say that you're about 36 years old, 37, then I'd say that 50 to 60% of your eggs are going to be normal. We can extrapolate that over to embryos. 50% of your embryos are going to be normal. If you had 10 embryos, that means that probably 5 of them may be normal. But if you've got those 10 embryos sitting there, that potentially means 5 embryo transfers you might have to do before you get to the first normal embryo. And that's a lot of heartache. That's a lot of time. It's a lot of stress. It's travel, and it's a lot of money. So the benefit of PGT in that scenario is that we can test those embryos so that we know which of the embryos are chromosomally normal. If you've got 5 of them that are normal, and we identify which 5 those are, because you can't tell from looking at them. It's not about the embryo grade or anything that we can do by looking at that embryo under a microscope. If we do the testing and we see that these are the 5 that are normal, we know that that's obviously where we're going to start, because any one of those normal embryos gives you about a 60 to a 65% probability of having a pregnancy. And that's the highest outcomes, the best results that we can expect with IVF. So that's what PGT is. PGT is testing those embryos to see which ones are chromosomally normal. We can also do that to determine gender. So if you're doing IVF for gender selection, you know that you really want to have a boy this time because you've got 8 girls at home in the house. God bless you. And we can do that. And that's what we do with PGT or with PGTA. There is a type of PGT, of pre-implantation genetic testing, that is known as PGTM. PGTM selects for a mutation. So for instance, if both you and your partner are sickle cell disease carriers, and you have a 1 in 4 probability, if you have sickle trait, of having a baby with sickle cell disease. We can test the embryos, do PGT-M to determine which are the embryos that do not carry the disease of sickle cell. And so that's a different story. So the genetic carrier screen, the beacon carrier screen, is to see if you are a carrier of one of these genetic diseases. Standard PGTA tests the chromosomes, the genetic material of your embryo, to see which are the ones that are more likely to be normal, so that it decreases the number of unsuccessful transfers that you may have to do. Now, people think all the time, oh, well, I'm of a certain age, so I need to be doing PGT, don't I? Don't I need to do that test? We're very afraid of having a baby with a genetic syndrome, Down syndrome, or something else. Well, again, in reality, the probability of having a chromosomally abnormal baby with a live birth from IVF is very, very low, because in most of those situations, the embryo either doesn't implant at all, you never get that positive pregnancy test, or it implants, but it does not continue to grow. So sometimes people say, well, I've got one embryo and we want to do PGT testing on it. And I say, well, certainly we can do whatever you'd like to do, but the fact of the matter is, with one embryo, your body's going to give you the same information. You're going to put that embryo in, and it's either going to stick because it's normal, or it's not because it's not. So I don't know that you necessarily need to pay the lab to tell you about that one embryo. Now, different people have differing opinions on PGT, and some people feel like, well, I don't want to do any transfer at all unless I know that embryo has a 60% probability of getting me pregnant. Well, that is an opinion, although as I say, people do have differing opinions. So hopefully that answers your question there, Melissa. Hi to Kelly. Looking forward to seeing you Saturday for your transfer. Jessica's asking, how far in advance do we find out about the egg retrieval date? And again, so you notify us on cycle day 1. We plan things out. We know that your stimulation is likely to be and is typically 9 to 12 days. And so in that scenario, we can kind of guess about a window, but we will not know exactly the egg retrieval date until you do your trigger, which is 35 hours prior to the retrieval. Okay. Hi, Melissa. Positive Receptiva testing. Receptiva is a non-invasive way to test for endometriosis. So it used to be the only way that we could test for endometriosis was to do surgery on you, right? Is to do a laparoscopic surgery, put a little camera in through the belly button, take a look around, see if we can find endometriosis. There's a non-invasive test called Receptiva, and if you want to look at that website, it's receptivadx.com. That looks for a particular marker in the lining of the uterus, in the endometrium, which we can test for by doing an endometrial biopsy, which is a little straw that goes inside, sucks a little piece of tissue out, and it looks for a marker that's known as BCL6. If you are expressing that inflammatory marker of BCL6, then it is highly associated with endometriosis. If that's the case, the recommendation is that you take 60 days of suppressive medication. And that medication is either Lupron, Orilissa, or Myfembree. And what that does is that it turns down the volume knob. It suppresses the endometriosis and allows that inflammation that's causing a miscommunication between the brain and the uterus that can prevent an implantation. So 60 days of suppression, Melissa, increases the probability of a successful transfer from less than 10% to greater than 60%. So that's a pretty powerful thing right there. I'm glad you did the Receptiva. I support the use of the non-invasive test when we can. A special hello to the Bama gal, and I would be remiss if I don't say hi to my dear mom and dear old dad, cavelling away in beautiful Lower Alabama, in Mobile, Alabama. One of my favorite places to be, and two of certainly my most favorite people, mom and dad. Thank you for watching. And a special hi to Jody. Jody, I have some exciting news. I don't know if it's okay for me to say, but since you're not here, I guess I can say whatever I want about you, and there's not a whole lot you can do about it, right? Jody is my friend who gave me this beautiful sign behind my head, which some of you may be able to see. It may be backwards on a couple of these things here, but Fink and Friends, and this is what I'm fond of saying at the conclusion of my program, that fertility is not the book of your life. It's only a chapter. And I always say, lead with kindness and love, and most importantly, hope. That comes from Jody, who is absolutely a superstar in my book. Jody is an embryologist here in the Colorado Springs office, but not for long. She came here from Albany, New York, the Albany location, and she is moving to Sarasota, Florida, to be the director, the embryology lead in our Sarasota office, and she will be sorely missed here in Colorado. So let's see, baby OB boosters during a natural frozen transfer tomorrow, no trigger, and did an HCG wash. So yes, HCG boosters is the question. What is an HCG booster? HCG, of course, is the pregnancy hormone. You can take a little of that pregnancy hormone, give yourself a little sub-Q injection of it, typically from the time of transfer moving forward, and it is metabolized as extra progesterone in your body. And baby OB, that makes a big difference in a natural cycle or in a modified natural cycle. If you are doing a medicated cycle, FET, then frozen embryo transfer, then it really, the HCG booster doesn't make a whole lot of difference. And so I don't recommend it in that scenario. And that's because in that scenario, we are giving you a boatload of progesterone on your own. So to get a little bit of extra probably doesn't make a difference. But in that natural cycle, it does. So yes, please do an HCG booster. The only caveat I want to point out, and maybe you've heard me talk about this before, is that if you are doing an HCG booster, then what happens when it comes time to do your pregnancy test, right? Your pregnancy test is an HCG test. And so guess what's going to happen? Your first pregnancy test is going to be low positive because we're giving you HCG. So the real pregnancy test that tells us that yes, you are pregnant happens with the second pregnancy test, with number 2. So I generally find it's important to tell folks to be emotionally prepared for that eventuality. Your pregnancy test is going to be positive, but it's the second pregnancy test, when we see the hormone level continuing to go up, that will tell us that you are really, truly pregnant. Jay Hand asked, when taking my Fembri for endometriosis, can I start an FET cycle my next cycle after stopping? The answer is yes. In fact, that is the time when the data shows us that you will be most successful with your FET. And I generally recommend a modified natural. That's what I'd like to see you do. The default is always going to be a medicated cycle. It's really hard after being on suppression to do a completely natural cycle, because your body, it may take a little time for your body to start to figure that whole program out again and start to respond. So I would do a modified natural or a medicated cycle. But yes, the first cycle after suppression is said to give you amongst the highest outcomes. So yes, indeed. Hi to Kel Hobbs and to David. Hi, David, Tiffany, Jackie. Nice to see you. Let's see here. We got Liz is with us, and Miss D. Meg Britt asks if I need IVF due to having a tubal ligation about 9 years ago. Do I need to go through infertility testing? And how long is the IVF process from beginning to end? So, when you say infertility testing, there is some testing that you need to do. We need to know where your hormone levels are. That stuff is very, very important. And if you're going to be going through IVF, we absolutely want to evaluate your uterine cavity to make sure that there's no polyps or fibroids, bands of muscle, scar tissue, anything that's on the inside that may prevent your beautiful, perfect embryo from being able to implant. Because Meg, the issue there is that you're going to be making a big investment into creating embryos. And so the inside of the uterus needs to be just as beautiful as the embryo itself. So if you're making the investment, make sure the uterine lining is fine. And otherwise, it's really just blood tests. And again, one of those blood tests we're always going to recommend is the carrier screen that we talked about before. The test that you do not need to do, and let me underscore, underline, put it in bold, circle it, put an asterisk by it. You had a tubal ligation. You do not need to do an HSG. The HSG, the hysterosalpingogram, is the dye test. It's the X-ray type test that we do to show the shape of your uterus and what's going on with the fallopian tubes. It may be that you have a consultation with someone at CNY who orders by reflex, orders that test for you anyway. You had a tubal ligation. You do not need to do the HSG. Please don't do it. It is my least favorite test to perform on people because it's uncomfortable. It doesn't feel good. And you know what? It's another expense. And so, no HSG is necessary, but the blood tests, yes, they are. The process of IVF from beginning to end, well, I suppose it depends on when you talk about beginning, because if you're doing some hormone testing and the like, then usually that's what we call the diagnostic month that takes place before the actual stimulation. But the usual process is that you let us know on cycle day 1. Typically by about cycle day 3, you're going to do a baseline ultrasound and blood test. Within a day or two, you'll start your medication, which will rev up your ovaries, get things going, start making some eggs. That stimulation ideally lasts a minimum of 9 days and a maximum of 12 days. Now, there are situations that stim lasts for less than 9 days. That can affect egg quality. And there are situations where, because of a slow response, it may take longer than 12 days, and that may affect egg quality. So between 9 and 12 days is your stimulation. Then you get a trigger shot, which 35 hours later, you do an egg retrieval. Once we make the embryos, different things that we can do with the embryos. Meg, we can place an embryo back inside of you that same cycle as you had the egg retrieval. When we put an embryo back in, that's called a transfer. A fresh transfer is done the same cycle that embryo was created. We can freeze embryos and allow your body to recover, and then you come back a different cycle and you do a frozen embryo transfer. We actually thaw the embryo first, but it's called an FET, frozen embryo transfer. Or we can do the PGT testing that we talked about a little bit ago, which then involves the embryos being frozen. So if you do a fresh transfer, it's typically either on day 3 or day 5 after your retrieval. And then you go home after that. If you're going to freeze embryos, you can go home right after the egg retrieval. I generally like folks to stay overnight, just in case you don't feel well, that we're close by, so that we can help you in case you need it. And hopefully that answers your question there. Oh, let's see what else we got going on in here. Megan Downey says, my embryo results came back from my miscarriage and it was all normal. Miscarried at 7 weeks. Is this common with a normal embryo? Well, I'm glad you did the genetic testing on that embryo, because now at least, you know. But what that's telling us is, even though most miscarriages, like we talked about before, occur as a result of a chromosomal abnormality. If they tested it, there's no chromosomal abnormality in your embryo there, but that doesn't tell us anything about the millions of little chemical processes that all metabolically have to take place in the embryo. So it says, unfortunately, that means there was some metabolic issue in the embryo rather than a chromosomal one. And yes, it certainly does happen. Megan, I'm so sorry that you had to go through that. You guys might have heard me say before, I think one of the cruelest things to ever have happen is for there to be a pregnancy loss after IVF, because after going through that entire process and getting that positive pregnancy test and seeing that little heartbeat, if you're able, and watching things start to grow, it is truly a heartbreak, and our thoughts and prayers go out to you and with you, Megan. Back over to the Facebook side. Let's see what we got here. Nikki says, I'm excited to have a consult at the end of February. Well, I am excited that you have a consult at the end of February. How about that? Okay, Bridget is with us on Facebook. Good evening. I almost finished with my 90 days of suppression from Oralissa. Okay, so you're doing 90 days instead of 60, and that is fine. During my CNY consult, I was told I did not necessarily need to get a period before starting stems for retrieval, but that I should wait 2 to 4 weeks after finishing Oralissa. Was wondering the benefit of what the benefit of waiting is. Will my retrieval potentially yield better results if I wait 4 weeks versus only 2 weeks? Well, first of all, I generally don't recommend doing suppression until you're right before your embryo transfer. It would be a rare day that I would suggest that you do suppression before an egg retrieval. And why is that? Because the sooner we get eggs from you, the better off we are. The younger you are when those eggs come from you, even by a month, 2 months, 3 months, that is a better thing. And that becomes more acute a process as we age. But the problem is with suppression is that it suppresses. And so just like sometimes people on a birth control pill for a prolonged period may be suppressed, the way the brain is talking to the ovaries to make eggs may be suppressed because the volume knob is turned down. Giving a little bit of time after Oralissa or suppression for endometriosis may benefit the ovary's ability to respond to the medication. So I think that's the reason why, although I have not seen data that proves that fact, that is my assumption. So that's probably what I would think there, Bridget. Paige is with us. Hi, Paige. Why would a baseline follicle be at 7 and then by the next monitoring down to 4? Because that may be a follicle or a cyst, a leftover function of the prior cycle. And so it is in the process of regressing or going away. So we check your baseline, we look to see where it is, and it's on the way down instead of on the way up. And that's okay as long as you're making other follicles and your estrogen level is going up, because the estrogen level is a direct reflection of the number of follicles you have in the ovary. Now, if you're doing a stimulation and you're looking at your estrogen level, to be honest with you, I don't make a whole lot of the estrogen levels. All it's really going to show me is, well, are you getting hyperstimulated? At CNY, we use a lot of the medication letrozole. Dr. Kiltz is a letrozole lover, and so letrozole is in many of our protocols, particularly in women who are over the age of 35 to 36. That's really when it is best utilized. But letrozole artificially lowers your estrogen level. So if your estrogen level doesn't look like it's going up or it's very, very low and you're on letrozole, that's the reason why. but that's probably what was going on there. If you had a follicle regressing, it's still left over from a prior cycle, or it was just a follicle that was hanging out that wasn't maybe it didn't have an egg in it. It wasn't deemed strong enough to continue to grow. So there you have it. Does CNY offer AMH testing? Absolutely. This comes from Sean Christina Donahue. AMH is one of the tests that we always do as part of our initial preconception labs. So we can certainly draw your AMH. Any doctor, really, anybody who can order a blood test can draw that AMH level from you, and that's why I did that Instagram post from yesterday about checking your AMH, because it is your biological clock. If you are 20 years old and we find that you have a diminished ovarian reserve, something is going on there, and you really want to know about it now, because maybe that's an indication to kind of think about starting a family sooner rather than later, or more importantly, to be able to freeze your eggs so that you have more options later on. Egg freezing has become such a straightforward thing to do. I can't speak enough about it. And honestly, the one thing, even as a general gynecologist, the one thing I wish had become more of a thing earlier in my career was egg freezing. Now we know how to do it very easily. And I wish I could have talked to everyone about it, because it is such a powerful fertility insurance policy that so many people wish that they could have done earlier on. If only they had known, if only that technology had been available, and really if only it had been affordable. Fortunately, it is here at CNY. So if you're thinking about it, think about it and talk to us. So yes, we do AMH testing. All right, what else we got going on here? Oh man, M. Afer, and I never know how to say your name there, M. Afer. Third beta today is almost 5,000, so thanks to CNY. Syracuse, congratulations. That means something very important for you, my friend, that 2024 is going to be a great year. Hi to Grace and Brock Tung, who are with us here, and a special hello to Alexis Lorente in Miami at the Miami Center of Excellence. She is the nurse practitioner extraordinaire, one of them at that location. And thanks for being here tonight. Rashmi asks, why are some women given birth control pills and other injections before egg retrieval? That's a good question too. So in many places, in many facilities, they will use birth control to batch their patients. And that may be because they only have an embryologist who is there 1 week out of the month or 2 weeks out of the month, or they only have an anesthesiologist who is there 1 week. So they try to get all of their egg retrievals done in one narrow period, or they try to get all their embryo transfers done in one period, and the rest of the month can be spent doing things like monitoring, and the doctor can go on vacation and so forth. So remember, the average fertility clinic does 100 to 150 egg retrievals a year per doctor. CNY does between 15 and 20,000 per year. Fortunately, not per doctor, but overall. So what that means is that we're doing retrievals and transfers every day of the week that we're open, which is every day but Sunday. So we don't need to batch cycles, and that's why we don't typically certainly don't require birth control for batching cycles. There are some cases where we will use some birth control, Rashmi, because we are trying to synchronize the growth of the follicles. We're trying to get the follicles to grow to be about the same size, so that you don't, by the time of trigger, have follicles that are 25, some are 20, some are 18, some are 16, some are 14, that they're all over the map. We'd rather them be, close to the same size. And so birth control will sometimes be able to do that, to help to kind of pull everything in together and synchronize the growth of the follicles. Sometimes we'll also use it for scheduling purposes, like let's say that someone wants to do their retrieval, but they know that this cycle, but the last week of the month, they're going to be on a cruise in the Caribbean. Well, so if we use a little birth control from the start of her period, we can control when her stim start date is going to be. And that's how that works. Let's see what else we got going on here. Ash says, my estrogen is 615 on cycle day 3. Is there any hope to save this cycle? Well, what that tells me is that, that's a little higher than we would like for it to be at the start of a cycle. So sometimes that may still be left over from the prior cycle and it can be coming down. There are some people who feel like, well, it doesn't really matter, because as long as the lining gets thicker when it's supposed to be thick because of the estrogen, then the number doesn't count. In fact, that's what Dr. Kiltz would tell you. There are others who will say, well, if the estrogen is higher than we want it to be, higher than about 150 at the beginning of the cycle, then it means that the FSH that we're going to give you, the medication, may not function as well to help you to recruit eggs. So the first thing I would do in that, I'd also kind of want to know about, do you have residual follicles in your ovary from the prior cycle? Sometimes we just look at that again in a couple of days and figure out where to go from there. Hi to Nadia and K. David, I think. Sorry if I'm mispronouncing. Do you treat patients with POI often? What are your success rates with IVF in these types of patients? So POI is premature ovarian insufficiency, and that definition can be very fluctuating. So really the term that I more use is premature ovarian failure. And essentially what that means is a premature menopause. So that's a menopausal level of hormone in a woman who is under 35 years of age. That's technically the definition. The pregnancy rate in those women with IVF is essentially 0. I would not suggest that you do IVF if that's the situation, because odds are it is not going to work with your own egg. So donor egg is the typical treatment for that situation. Now, we do find that sometimes women with premature ovarian failure can kind of flip in and out of that situation, that they may still have some eggs that are left in the ovary that might periodically just kind of come out on their own. I had a wonderful patient of mine from Miami who I will remember until the day I die. I still consider her a friend, who had premature ovarian failure and had 2 spontaneous pregnancies on her own, much to the dismay of everyone who was involved in her care. No one could understand, but sometimes the body doesn't read the book. How likely is that to happen? It is exceedingly unlikely. So I wouldn't bet money on it, and I wouldn't advise. But what can you do? Well, if we give you some estrogen, for instance, it may lower your FSH, and if your body responds very well to that, well, then maybe there's a chance. If you do a baseline ultrasound at the beginning of your cycle and there are some follicles there, then it may be that there's a chance that you could respond. Some people think about doing intraovarian PRP, and that's an option as well. But in general, with premature ovarian failure, most clinics will not allow you to do anything at all because the odds of it working are just so doggone low that they don't want to get you, I don't want to get your hopes up and get you involved in something that's going to cause you spending money without really a lot of hope for success. Now, we can certainly try some things, but again, realistic expectations are what's important there. Hi to Stacy, and Facing Destiny says, what is the best fresh eggs with frozen transfer or frozen eggs with frozen transfer? Oh, I see, for donor eggs. Okay. All right. So if you are going to get donor eggs, you will have a choice. you can. So doing a fresh transfer with embryos created from donor eggs can be very challenging to try to get your cycle to coordinate so that it is the appropriate timing for embryo transfer with your fresh embryos. If you're going to purchase embryos, um, you have a choice of purchasing either frozen eggs, and these are eggs. There's tens of thousands of eggs that have been donated for folks that come from women who are paid for those eggs. So you can purchase those donor eggs, or you can do a fresh cycle with a donor. The difference in that scenario is that um, eggs don't freeze as well as embryos do. And so what happens there is that the survival rate of an embryo being frozen is about 97%. Freezing an egg and thawing it, because it's so much more delicate a little structure, is about 80%. So if you're buying frozen eggs and then you go to thaw them and fertilize them, there is an expectation that you may lose up to 20% of those eggs. Whereas if you're purchasing eggs from a fresh donor cycle, and you purchase 8 eggs, you're going to get all 8 eggs. So that's the difference there. The other difference is that with a frozen egg, you can purchase those eggs tomorrow and schedule them for fertilization, relatively quickly. Whereas there's often a waiting list with a for a fresh donor cycle, because that person is going through the process. They're stimulating, or maybe they haven't started a stim yet. So there's a difference there. But as far as doing freezing those embryos is more commonly what happens. There's no harm to freezing the embryos, and doing a fresh transfer with a donor embryo is as I say, sometimes just challenging to get your cycle to match up with the timing of that fresh donor embryo, if that makes sense. Okay, let's see. Can't wait to head to Colorado. This comes from Deja and Rick Frazier. Well, we are looking forward to seeing you here. Alyssa says, I had a transfer and a baby girl in August of 2021. Awesome. I had to go to my OBGYN for an ultrasound today, and they diagnosed me with a septate uterus. I'm not convinced this should be my actual diagnosis. Wouldn't have been caught through all my ultrasounds and surgeries with you guys if that was the case. So what is a uterine septum? A septum is a band of muscle that runs down the middle of the uterus. And so let me bring in my friend here. This is Dr. Uterus. I'll take off her stethoscope. There we go. So a septum is when this part of the uterus here kind of goes in, and there is a band that runs either partially or even all the way down. So, it's possible that you have a septate uterus that just never got picked up. Usually you would see that on an HSG, the hysterosalpingogram. That would have almost certainly have been noticed. Use of pelvic ultrasound, unless it's really a good 3D ultrasound, may not really show that very well. So I too am a little suspect about that. It's possible, but it is also possible that you had a completely normal pregnancy and a completely normal delivery with the uterine septum in place. There is some controversy about whether a septum needs to be removed. The classic wisdom was that in a woman who had a uterine septum and who had recurrent well, it used to be thought that that's a cause of recurrent pregnancy loss. And so it's something that generally we kind of want to, really be able to look at to know that it's not there. And so we always thought if there's a septum, we have to remove that septum. And it's a very straightforward surgery to do, done hysteroscopically through the vagina. Those muscular bands there are really pretty really don't have much blood supply to them. So you just take a pair of scissors and you go, and they disappear. They just retract and they're gone. But there was recently a big study that looked at, is it necessary to treat those? And the study showed that there's really no difference in the live birth rate or in the miscarriage rate between women who have a septum in the uterus and those who don't. So it really challenged the conventional wisdom there. But do you really have a septum? I'd be suspicious. That can easily be diagnosed hysteroscopically or with an MRI or by doing an HSG. But a general pelvic ultrasound is not really the best diagnostic test for a uterine septum. Hey, you guys, we got about 5 minutes left on Fertility with Fink and Friends, as we do every Tuesday. It's great to be here, 4 o'clock Mountain Time, and we're here for an hour and try to get all your questions in. So let's see what else we got going on here. I wanted to say, this comes from Erica. Oh, thank you, Erica. I wanted to say thank you, Dr. Fink. I'm pregnant after my 3rd transfer, 5 weeks today. Woohoo! Celebration. That is fantastic. Rashmi asks about tips for thickening the uterine lining. I presume you're talking about, and any supplements for doing so. Well, so for embryo transfer, there are 5 supplements that you should be on: prenatal vitamin, vitamin D, vitamin E, CoQ10, and L-arginine. L-arginine increases blood flow and will likely help to thicken that lining. We also think of intrauterine PRP. A baby aspirin also helps blood flow and to increase the lining. And of course, that's why we use the estrogen hormone to increase that lining there. Hi to Nurtured Shannon. Nice to see you this evening. Carrie asks, I have 4 frozen embryos. I've decided that with my age and some health issues that I would like to have a surrogate, or a gestational carrier is what we generally call that. My sister has offered, can I do this with CNY? Absolutely, you can. Yes, indeed. So we have a special team known as our donor team that is really dedicated to helping you through that process. So what you would want to do in that scenario is to simply reach out, Carrie, to the donor team. You can email through the portal, explain the situation, and they will help you one step along after the other. Very straightforward thing to do. And it's great. Thanks. Your sister is from heaven, Let's see. Haboshali says, I had a runny nose the day before I transferred. My transfer with no fever. Is it going to affect my success? I tested negative for COVID. So COVID can definitely have an impact, but if it's just a general upper respiratory infection, a viral, a viral cold, it is so common. If you had the choice, I'd say, wow, if you're really sick, you're really feeling bad. Certainly if you had a fever, I wouldn't be excited about you doing an embryo transfer. But if it's just a common cold upper respiratory infection, I don't think that should be an issue. Let's see what else we got going on here. Hey to everybody. Got a great attendance tonight. Thanks so much for being here. Let's see. Angela is here. Angie says, I said Angela, but Angie, 2 of my 6 embryos were normal at 44, almost 45. When I got my second euploid, I was very lucky. My first euploid failed and the second was successful. Thank you, CNY. Angie, that is incredible. Yeah, that's really fantastic. And congratulations to you. That is so awesome. Shelby is here. Shelby is 6 weeks pregnant from an FET, and now you have COVID. Oh, I'm scared. Well, I understand. And, there's been so much controversy over what are the effects of COVID on a pregnancy. And what you can do is sort of take it day by day. In this situation, you can't take the COVID away, and you're not going to take the pregnancy away. So keep yourself from getting a fever. That's probably the best thing that you can do, is to maintain your core body temperature as normal. That would be Tylenol, because we don't use ibuprofen in pregnancy. And that's the best thing you can do there, Shelby. And best of luck. Hope you feel better. Let's see. Megan says, I did an IUI and miscarried at 7 weeks. My progesterone and HCG all look good. Genetics came back and the embryo was normal. Is this normal? Heartbroken knowing it was a healthy embryo. Again, situation there is that tells us that genetics were fine, but it doesn't say anything about all those little chemical processes that have to take place in the embryo. And any one of those goes wrong and the pregnancy will stop growing. But what it does say is that you, my friend, were able to implant an embryo. Right? So you made it a half a step in the right direction. It is definitely a heartbreaking scenario, but you almost got there. And that tells me that you will get there again. Well, I'm afraid it is about that time, my friends. Thank you so much for being with me as every Tuesday evening. I will take my hat off again to my friend Jody to say, lead with kindness, lead with love, and most of all, have hope every single day because the sun rises and each day is a new one. This fertility business is not the book of your life. It is only a chapter, and we are here to help you rewrite it. God bless you all. Thanks so much for being here. Until next week, I'm Dr. Randy Fink from Colorado Springs. Good night.